The current outbreak of monkeypox in endemic and non-endemic regions has brought international interest. It's possible that all persons participating in healthcare may experience a patient who's been exposed or infected with monkeypox. Monkeypox was first identified in 1958 in Denmark among primates used for research. The first human case was in 1970 in the Democratic Republic of Congo. Sporadic cases have been mostly in African countries, but some outbreaks have been linked to travel. On July 23, 2022, the World Health Organization director declared the current monkeypox outbreak a public health emergency of international concern, overriding the WHO Emergency Committee, which decided 6-9 against recommending this. Since the International Health Regulations was revised in 2005 in the aftermath of SARS, the WHO has declared a public health emergency of international concern 6 times before for H1N1 influenza, polio, Zika, COVID-19, and Ebola twice. Currently, the WHO has declared 3 emergencies worldwide: COVID-19, polio, and monkeypox. This places major strain on the national health systems. Monkeypox is endemic to tropical rainforest regions of West Africa. Most cases outside of this area is from international travel or from importing animals infected with monkeypox. Before 2022, there have been outbreaks in the US, UK, Israel, and Singapore. There are 2 genetic clades of monkeypox, the Central African clade and the West African clade. A clade is basically a group of organisms that includes a single ancestor and all of its descendants. Clades represent unbroken lines of evolutionary descent. Infection of the West African clade is typically more self-limited disease with a case fatality rate of 3 to 6%, and this is the type that is being isolated from the current new 2022 outbreak. The other type, the Central African or Congo Basin clade, has a higher transmissibility and case fatality rate as high as 10%. Now it is to note, no confirmed monkeypox-related deaths have been reported in the current outbreak, and only 8% of patients in Europe have been hospitalized for isolation or treatment. But this could change if the infection reaches more vulnerable populations, such as pregnant patients, children, or those who are immunocompromised. As of July 25th, the CDC has reported 3,487 confirmed monkeypox cases in the U.S., but cases are probably significantly underreported. Transmission from animal to human can occur by bites and scratches from infected animals, or this can occur by preparing meat of the infected animal. Infected animals may show pox-like lesions. Human-to-human transmission occurs via direct skin-to-skin contact with lesions on the skin and indirect contact with contaminated fomites like bedding or clothing. Transmission can also occur at close proximity through exchange of respiratory secretions containing live virus. Here's a timeline of monkeypox cases since 1970. The first case was a 9-month-old in a remote village in the Democratic Republic of Congo. Since the smallpox vaccinations have stopped being universally administered, the conferred cross-protection and loss of immunity may be contributing to more outbreaks. When a patient becomes infected, they may first experience the prodromal symptoms of fever, headaches, chills, malaise, and lymphadenopathy. Then they develop the characteristic rash that starts at the mouth and spreads to the face and extremities, including the palms and soles. Lesions begin as macules, then progress to papules, vesicles, pustules, then scabs. The lesions can cause pain and itching during the healing process. Patients can have from 10 up to 150 lesions, and typically they're at the same stage and can last up to 4 weeks. Patients are infectious from the time a symptom starts till the scabs fall off and a new layer of skin is being formed. Complications can occur such as bacterial superinfections, encephalitis, pneumonitis, and conjunctivitis and keratitis. In the current 2022 outbreak, atypical presentations are occurring. Patients may not have prodromal symptoms, and the rash may be limited to the genital, perigenital, and perianal areas and present at different stages. When you have a suspected patient, be sure to ask about travel or exposure to close contacts. To test the patient, obtain a specimen from a skin lesion to send for molecular testing by PCR. More than one specimen should be obtained from 2 separate lesions on different parts of the body, and the lesion should be unroofed to adequately sample virus-containing secretions. Certain laboratories can perform direct PCR testing for monkeypox specifically, whereas others perform generic orthopox virus testing that requires confirmatory testing for monkeypox at a reference laboratory. First-line treatment for monkeypox is supportive care in managing complications such as bacterial superinfections or ocular infections to prevent corneal scarring and loss of vision. Treatment for ocular lesions may include ophthalmology consults, lubricants, topical antibiotics, and topical antivirals such as trifluridine. Currently, there are no FDA-approved treatments specifically for monkeypox, but there are some antiviral agents such as cidofovir, brincidofovir, and tecovirimat that can be used. Additionally, Vaccination immunoglobulin IV or VIGIV was used for complications due to Vaccination vaccination previously and can currently be used. Currently, tecovirimat, cidofovir, and VIGIV are in a strategic national stockpile that can be accessed through the CDC by request during outbreak scenarios. The CDC is also developing expanded access investigational new drug use protocols to be used for brincidofovir for treatment of monkeypox. There are a few vaccines being used to prevent and treat monkeypox. There are 3 vaccines being considered. The ACAM2000, which is the live virus. This can, though, have serious adverse effects such as myopericarditis. The other vaccine is Jynneos. It is a non-replicating modified virus and was licensed for both prevention of monkeypox and smallpox in the U.S. in 2019. Last is the Aventis Pasteur smallpox vaccine, which is experimental and similar to the ACAM2000. This may be used in the U.S. under investigational new drug protocols or via emergency use if the other 2 vaccines are not available. The ACAM2000 and Jynneos have some efficacy when used in post-exposure prophylaxis. To prepare for potential deliberate biological threats, the U.S. stockpiled 100 million ACAM2000 doses and 36,000 Jynneos doses and seeking to amass more. The Biden administration recently issued a national monkeypox vaccine strategy, including deploying nearly 300,000 vaccine doses. This is interesting as monkeypox has been endemic in Central and West Africa, but these regions have not been prioritized for vaccine distribution except for sporadic clinical studies. High-income countries are already negotiating with manufacturers to procure additional vaccine doses, reminiscent of the COVID-19 pandemic. Exposure risk can be classified into 3 categories. High, which is direct contact to exposed persons, broken skin or mucous membranes, and, quote, materials, skin lesions, or body fluids of a patient, also being in close contact during aerosol-generating procedures. Intermediate is direct contact of intact skin with material skin lesions or body fluids of patients, also being within 6 feet of a patient for more than 3 hours, or giving care to a patient without appropriate protective equipment. Low or uncertain risk is giving care to a patient while wearing appropriate PPE. Post-exposure prophylaxis is given to high or intermediate risk persons and is recommended to be given within 4 days of exposure, yet in some places it has been given up to 14 days post-exposure, given the possibility that it will help attenuate the infection. Pre-exposure prophylaxis is currently recommended by the CDC for laboratory personnel who will be testing for monkeypox and personnel handling cultures or infected animals and certain public health response teams. Patients with monkeypox should be interviewed regarding contacts and contaminated fomites. Those exposed should be monitored for symptoms for 21 days after last exposure and offered vaccination where post-exposure prophylaxis is appropriate. People with confirmed monkeypox should be isolated until the lesions have resolved and new layer skin has formed. Waste is considered Category A substance, a pathogen that is life-threatening or causes permanent disability, and should be handled in accordance with U.S. Department of Transportation hazardous materials regulations. Pet rodents are at the highest risk for human-to-animal transmission and should be quarantined for 21 days and exclude infection through testing. A familial cluster of 2 cases of monkeypox occurred on May 14, 2022. They had no history of travel to endemic regions. Since then, thousands of cases have been reported in Europe, South America, and the Middle East, Canada, and the United States. A majority of cases have been in young men between the ages of 25 to 35 years old, whom self-identify as gay, bisexual, or other, such as men who have sex with men. It is unknown if monkeypox can be sexually transmitted, yet the UK recommends abstinence during active infection and for up to 8 weeks after recovery. It is unlikely that the ongoing monkeypox outbreaks will lead to a global pandemic on the scale of COVID-19. Monkeypox is not a novel virus, and there is experience from previous outbreaks regarding how to prevent propagation of the infection. Monkeypox is definitely a concern, and clinicians and the general public should be aware of the signs and symptoms of the disease, as early post-exposure prophylaxis can provide some benefit.